Good afternoon, everyone.
Good afternoon, Doctor.
Good afternoon.
I hope everyone is doing well, keeping safe,
Good afternoon, sir.
maintaining good
Yeah, good
nutrition.
afternoon, Dato.
Good afternoon.
Good afternoon, Dato.
Good afternoon.
Okay, so let me just do a quick check-in with our my host to see whether everything is okay. Hold on. Is it good to go? Okay, great, excellent. Okay, so good afternoon, everyone. My name is Anthony, and I will be moderating this afternoon's forum on COVID-19. Our host of this Zoom session is Ms. Puluan and a team of Nur Hayati and Nur Fatin, and they will be helping to monitor the people coming in for the purpose of security. Okay, so firstly, a warm welcome to all of our participants joining us today, Taylorians and members of the public from wherever you are. Before we move on, just some ground rules for our audience. We have a lot of ground to cover today, so I respectfully ask that our audience please hold your questions for the panel members until around 3:45 p.m. or so. After that, please use the chat window to type in your questions, and I will attempt to relay as many as possible to our panel. I will, of course, prompt you for this. Now, as is always the case, we may not have time to field all questions, so I apologize in advance if we do not actually get to your question. The panel members have kindly consented that if you wish to contact them individually, you may do so via email or Twitter accounts that will be posted up on screen by our host towards the end of the session. So on to the event. The purpose of this event is to provide a balanced and factual view of the situation with regards to COVID-19 from the aspect of the disease, its diagnostic test, and treatments within the Malaysian context as far as possible. I will first introduce our panel and discuss specific topics with each of them for about 45 minutes, and then followed by questions from our audience until about 4:30 p.m. So please let me introduce our panel members today. First up, Dr. Christopher Lee. His background of infectious disease specialist and a member of the Selangor COVID-19 Task Force and adjunct professor at the School of Medicine, Taylor's University. So Dr. Chris graduated from the University of Malaya with his MBBS and subsequently obtained his MRCP in the UK in 1989. He trained in infectious disease at the Regional Infectious Disease Unit City Hospital in Edinburgh, Scotland from 1993 to 94. And since his return from the UK, he has had a distinguished career serving our country in various roles in the Ministry of Health as well as in professional societies and non-governmental organizations such as the International Society of Infectious Diseases and the Malaysian AIDS Council. Welcome, Dato. Next up is Professor Dr. Chong Pei Pei, biomedical scientist, Head of Research at School of Biosciences, Taylor's University. Professor Chong is a biomedical scientist. Excuse me. She obtained her bachelor's in biochemistry and PhD in biochemistry and applied molecular biology from the University of Manchester. Her research interest includes pathogenesis and host pathogen interactions for infectious diseases and molecular diagnostics for infectious diseases. She has passionately applied her knowledge towards explaining multi-drug resistance in bacterial and fungal infections, investigating how viral infections cause cancer, and understanding cancer genetics. She has more than 100 publications to her name and several patents related to diagnostic testing technology for fungal infections. Welcome, Prof. Chong. And finally, we have Emeritus Professor Dr. P.T. Thomas, pharmacist, who is the Executive Dean of the Faculty of Health and Medical Sciences at Taylor's University. Professor Thomas obtained his master's and PhD in pharmacology and toxicology from the University of Texas, Austin. He then worked for the Ministry of Health at Hospital Kuala Lumpur and the National Pharmaceutical Regulatory Agency before beginning a storied career in academia, where he trained many outstanding pharmacists in our country. He has served with the Malaysian Academy of Pharmacy and the Pharmacy Board of Malaysia as well. His main interest is in social pharmacy and toxicology and continues to publish today in areas of pharmacy practice and proper use of medications. Welcome, Professor Thomas.
Thank you, Tony.
So with that, I'd like to begin our program. So I'd like to thank everyone for joining us on this forum. And let us begin our discussions with panel members. So first off, I'd like to start with Dr. Chris. Dr. Chris, we have had viral infections before. In fact, even the common cold is here with us all the time. And SARS recently, MERS, HIV. In your opinion, what is different about COVID-19?
Well, I think COVID-19, the first thing we have to remember is a novel infection. So nobody on this planet has ever met this virus before. Of course, a couple of years ago, we had the novel H1N1 of 2009. And that spread very quickly around the world as well. So in terms of infectiveness or the way it spreads, the speed-wise, I think both may be about the same. The big difference between COVID-19 and that of H1N1 is the mortality. I know during the early weeks and maybe the first month or so of this pandemic, people are talking that why are we worried so much about COVID when flu kills more people perhaps in the States. Now, well, the difference is they kill a lot of people at the same time. And I think the good case to look at is the States. You know, up to 8 weeks ago, they had their first case, if I'm not mistaken, 8-9 weeks ago. And now they have 1 million cases around the country. They have the highest number of deaths in the whole world. So it spreads extremely fast. So I think the main two issues are the way it spreads, how fast it spreads, and number two, the mortality is still very significant. Of course, in between, besides this coronavirus, we had 2 other coronaviruses like SARS and MERS-CoV, and both of this I was integrally involved. But I must say, this is uncharted waters. I have not worked in a situation like this before. The mortality, of course, is higher in SARS and MERS-CoV, but in terms of transmissibility, it's nowhere near the threat of COVID-19. The number of infections around the world was fairly small in SARS, and in about 7 to 8 months, it disappeared from the face of the earth. Until today, we have not seen a resurgence of SARS. So I guess these are the 2 main things that differentiates COVID-19 from her earlier sisters.
Okay. Doctor, when you say difference in the infectivity and transmissibility, could you maybe give us a bit more detail about what you mean by that?
Well, in terms of the incubation period, of course, it's pretty similar to the other coronaviruses. And we know that the incubation period may last from a day to up to 14 days. But in terms of the R0, the number of infections one case can spread to, initially in China, it was something like 2.6 to about 3. And we saw how Wuhan in that first month or so exploded so rapidly. I think from the time they officially, WHO was notified officially, when the WHO notified to the world, I think that was almost at the turn of the year. And within about 3 weeks plus, Wuhan was locked down. And I think all of us were amazed because we have never seen a city locked down like this in most of our lifetimes. And I think all of us were shocked, all of us were surprised. Some of us perhaps thought China overdid it. But well, lo and behold, more and more of us are following what China had to do. Well, we are in the 6th week or 7th week of our MCO now. So we are doing that because of the R0 that is significant. Social distancing brings that R0 down. So based on the Chinese initial data, it was about 2.6 to about 3. So that is how you measure how effective the virus is. I need to say, the higher the R0, the more effective it is.
Okay. So in terms of comparing with, say, the the common cold, for example? Is there a difference in how easily you can transmit it? Or is it roughly the same?
The good example would be it's in the way of transmission, it's more like influenza. Now, in SARS and MERS-CoV, we are comfortable to say that you are most likely to transmit when you have symptoms. And those days, fever was a distinct initial manifestation, especially for SARS. But in this case, it's a bit similar to influenza, that even before your real symptoms come in, you can be transmitting the virus 1 to 3 days before you become symptomatic. So in the earlier months, I think Shanghai was the one who first broke that possible data that there could be asymptomatic transmission. That has been well proven now, but more likely it is not asymptomatic transmission, it's actually pre-symptomatic type of transmission. In the Diamond Princess, remember the famous cruise ship, nearly half of all those who found positive, who were screened positive, were actually asymptomatic. But when they followed these patients up, if I'm not mistaken, more than 3/4 of them actually developed symptoms a few days later. So pre-symptomatic transmission occurs, and that makes our monitoring, our detection harder. Thermal scanners, do they work as well for COVID-19? Clearly not as well. It doesn't do any harm if you have thermal scanners, by all means put it on at the airports. But we cannot just depend on thermal scanners to catch every COVID-19 case, because we know that before you develop symptoms, for the couple of days prior to that, you are probably transmitting it already.
This presents an interesting a problem for us, because if we are not symptomatic and we go about doing our daily lives, right? By the time we exhibit symptoms, it would have been a bit too late in terms of restricting our exposure to other people.
Right. So based on this understanding, a few things became more important. I'm sure you remember, and I was the one who also promoted this during the early weeks of the outbreak. We are saying, please do not compete with your healthcare workers to wear masks. If you have no symptoms, when you go out to Jaya Grocer, don't have to wear a mask. Did I say it? Yes, Christopher Lee did say it, no question. But as more and more data came through that asymptomatic or pre-symptomatic transmission occurred, then we had to change the way. We know that people may unknowingly be transmitting. So what was therefore important is universal masking. So that now if today just start coming back from Sungai Buloh Hospital, stop to buy petrol, I used my mask when I went down to buy gas, you know, I don't have symptoms, but I don't know whether I've been infected. So the masking now is important for other people, not so much for ourselves, but other people. So that is a big shift in WHO's approach. WHO now is promoting universal masking as well, isn't it? Whereas earlier on, because we thought that asymptomatic transmission wasn't such a big deal.
Okay, thank you. I'll hang on to that thought. I'd like to come back to that again sometime.
And just before Prof. Chong answered, obviously to deal with this asymptomatic or pre-symptomatic transmission, clearly is testing. So I'm helping you introduce Prof. Chong.
Thank you, Dato.
Welcome.
Okay, Prof. Chong, can we discuss what kind of diagnostic tests are available today? And if you could explain a bit how these tests work.
So basically, there are two main types of tests that are used widely at the moment. Sorry, can you hear? Yes, okay, sure. Thank you. So basically, there are two main types of tests available. The first type is a nucleic acid-based test. So this type of test actually detects the presence of the virus, specifically the genetic material of the virus, and is known as the RT-PCR test. And the second type of test is the serology test or blood test. And there are actually two types of blood tests. One which detects the antibodies produced by our immune system towards the virus. And there's a third type, which is also a serology test, which detects the presence of specific, what we call protein signatures or antigens found on the virus particle, so which is quite specific. So this third type of test is much newer and not so much in use currently, but our Ministry of Health has actually procured this antigen rapid test kit from a South Korean company. And this, I understand, is to be used for mass screening. So yeah, basically these are the main types of tests that are available currently.
In terms of rolling out this test, what would be the circumstances in which the genetic material test is best, and what circumstance would the serology test be better?
Diagnostic value and whether it is used for surveillance purpose. So this type of test is the nucleic acid-based test, or RT-PCR. So it basically looks for whether the virus is present or absent. And it's designed basically to detect specific genes found in the virus genome or RNA. So this test tells us whether you are currently infected with the virus or not. So typically the sample which will be collected is swabs from the inside of the nose. So, but this type of test requires specific equipment which can be costly, and also expert, well-trained lab technicians to perform in a certified hospital laboratory. The actual test itself takes about 4 to 6 hours to run to get the results. But due to logistic reasons, so the lab normally takes about any time from 24 to 48 hours to complete the test and inform the results to the doctors as well as the patients. So with this type of test, as long as you are still infected with the virus, you should get a positive result. So it's like a diagnostic test, it's a confirmatory test. So for the second type of test, which is the serology test, so for the antibody serology test, it will detect the presence of antibodies in our blood produced by our immune system towards the virus. So this would show actually whether you have had a previous infection or not, or it may also show whether you are still having progressed infection. But it doesn't tell you definitively whether you still have the virus or not in your system. So what are antibodies? So maybe I have to explain a little bit for the lay person. So antibodies are proteins produced by our blood cells mainly to fight off viruses and other invading germs. So because it takes our body from days or even to weeks to produce these antibodies, so this type of antibody test may not actually tell you whether you have a current infection or not. So it all depends, the test result, it all depends on when you were infected and when the test was done. So essentially, you may test positive for an antibody test, but it doesn't mean that you necessarily still have the virus in you. You know, it may be the case that you have already recovered from the virus infection, but because the antibody is still present in your body, so you will get a positive result. But in actual fact, you may have already recovered and you will no longer be able to transmit the disease to someone else. But conversely, you may have an active infection with live virus in you, but because of the timing when you do the test, there's a window of, let's say, a few days that the antibody test will not show as positive. So if you do the serology antibody test very early on of your infection, then it will show as a negative result. But in terms of the timing for the test result, actually this antibody test is much faster than the RT-PCR test. So there are different brands of this antibody test from different companies, but it takes typically from around 30 minutes to 1 hour to get the result. But however, if the antibody test is done when you are like in the middle stage of infection, then it will definitely reflect your true status of infection. It will show as positive result.
Okay.
So the chief difference between the two tests is that the nucleic acid RT-PCR test tells us whether you have a current infection or not, whereas the serology antibody test tells us whether essentially whether you had been infected or not. Right. So
yes, thank you. For the antibody levels in our blood, how long do they remain high? Better use of a word. And if they dip after a while, how does that affect our ability to test for the presence of antibodies?
Yeah. So basically, most of the tests they test for two different antibody subtypes known as IgM and IgG. So the IgM antibody will appear first, and then it will dip, and then you won't be able to detect it after a couple of days or a week. Then for the IgG antibody, it will last longer, but it will appear later. So that is why I mentioned in the beginning stage, because the antibody is either absent or present in very low levels, most of the tests will not be able to detect these antibodies at the early stage of infection. So it is important to have a test that actually tests for both the IgM as well as IgG, and then combine the results and interpret whether the patient or the person is in early or middle stage of infection or late stage convalescent stage of the infection.
Okay, thank you, Prof. Chong. You set me up very nicely for my next question to Prof. Thomas, actually. So from testing, so once you've tested positive, then we are talking about potential treatments here. So Prof. Thomas, can we discuss about available drugs currently for the treatment of COVID-19, and how close are we to a vaccine for its prevention?
Thank you. Thank you for the introduction and the question, Tony. So the short answer to that question is, this is a new virus and there is currently no specific treatment for COVID-19 and no specific vaccine for the prevention of COVID-19 infection. Now, this is unlike antivirals, are unlike antibiotics, which have a spectrum. Antivirals, although we have antivirals in the market, mainly developed for HIV, it does not necessarily mean that they can work for all types of viruses. Antibiotics have a spectrum, they work for a group of bacteria. That's not the case with antivirals. As far as a vaccine is concerned, again, it's the same thing. Although we have antiviral vaccines like the flu vaccine, that will not work for the COVID-19, to prevent COVID-19. So we don't have any vaccines yet. Then probably the next logical question that people will have is, so then what are people in the hospitals being treated with? So currently, people are mainly being treated symptomatically. So if you have a fever, you will be given paracetamol. If you have breathing difficulty, then you will be given oxygen or other respiratory drugs to help you with your breathing. In addition, some hospitals try drugs that have been used for HIV or other viral infections. And that's where people have also tried to use antibiotics like azithromycin and hydroxychloroquine. These are all not specific for COVID-19.
Could you expand a little bit more about the debate around hydroxychloroquine?
Okay, hydroxychloroquine has been around for a long time. It is approved in Malaysia. It has been in the Malaysian market for some time, and it is approved for rheumatoid arthritis and for SLE and also for malaria. A sister drug related, not the same, very different, but the name sounds similar, is chloroquine. Chloroquine is also used for the prophylaxis of malaria and also used for rheumatoid arthritis and SLE. But we hear a lot about hydroxychloroquine because it has been talked about much more by different people as a possible treatment for COVID-19. But why is an anti-malarial or a rheumatoid arthritis drug being thought of for the treatment of a viral infection? This is because they have been tried in other viral infections. For example, during SARS, they have been tried, but there has been no proof that they really work as antiviral drugs. One of the things that we need to remember is hydroxychloroquine and chloroquine. They are drugs that are effective in certain conditions for which they are approved. But at the same time, we need to remember that like all medicines, they also have side effects. And some of these side effects are inherent to the drug, and some of them are dependent on the dose that is used. So you cannot assume that a dose that is used for the treatment of rheumatoid arthritis will be appropriate for treatment of COVID-19. And if it is used in a higher dose, whether the side effect profile will be same. So there are concerns about the use of hydroxychloroquine. There are concerns on its effects on changes in the ECG, indicating heart function. There are concerns about its ability to cause convulsions and retinal damage. So if you look at the literature, you'll find a whole list of side effects that can be caused by hydroxychloroquine. So it is still experimental in the treatment of COVID-19.
Okay, let me pivot to a more antiviral drug. So let's talk about remdesivir. So a report in the Lancet yesterday and today, more reports are coming out from the US about the outcomes of these remdesivir trials. Can you add light to that?
Okay, so remdesivir is an antiviral drug. In some ways, it is experimental because it was not marketed in Malaysia yet. But how did we come to know about remdesivir? Because it was used for treating Ebola in Africa. And there was some success attributed to remdesivir. So Malaysia is willing to try it out. It is part of the number of drugs that are being trialed for its efficacy in treating COVID-19. Because it was not a drug that was already registered in Malaysia, the drug had to be given special permission, a clinical trial import license from the NPRA to bring it in. And it also got ethics approval from the Medical Research and Ethics Committee, MERC. Both of these approvals were obtained in record time. And so now remdesivir is part of the drug that is one of the drugs that is being used in a clinical trial.
Okay, thank you very much, Prof. Thomas. Now, if I can move back to Dr. Chris. We talked about asymptomatic already previously. Knowing what you caution about just now, what kind of precautions should we take for us lay members of the public going around doing our business?
I mean, now we have the MCO, and the MCO basically is a form of enforced social distancing. Many of us in the world, not just Malaysia, if we are left to our own devices, we probably are so sociable that we don't like to socially distance ourselves. So governments of the day everywhere, including maybe not Donald Trump, but everybody else, is trying to use the law to stop us from socializing the way we used to before. So it's basically the spirit of MCO is social distancing. As we talked about earlier, yes, patients who are symptomatic, they will transmit, but because patients who are asymptomatic, they can also transmit. Therefore, the MCO becomes more important. Social distancing becomes more important. So now with the MCO on, it's pretty easy. We are dictated by that. Some of our liberties have been taken away. So they'll tell you what you must do when you go out, etc., when you can, where you can go, what you cannot go. That's the easy part. That's the easy part. It's a no-brainer. MCO will work. I'm not taking anything away from MOH, but there's no country where MCO hasn't worked. It will work. The tricky part is when it's lifted. When we are back, some of our liberties are returned to us. So Malaysians all flock to the mamak shops again. Well, I do miss my mamak shop a bit, yeah, but will that happen? Will people congregate again? That's a fear. So clearly, I think we have to prepare ourselves for the lifting of the MCO. I'm sure there will be still some restriction in place, but I think it's important for all of us, individuals, organizations, universities perhaps even, to start planning our own protocols, if you like, of our own SOPs. What is the new normal now? Is it back to usual? It cannot be back to usual, because no matter what MOE say, there will not be zero infection out there. No matter the way we are testing, even if we can test a bit more, we will not be able to test everyone. There will still be some pockets floating around. And now our focus seems to be on the foreign workers, migrant workers, all right? Very similar to what what we are seeing in Singapore now. You know? And we have the same problem with our foreign workers as well. So we need to monitor that. So there must be a new norm. So for all of us as citizens of the country or living in this country, we have to ask ourselves, what is our new norm? Universities have to ask ourselves, I'm talking to the emeritus professor, of course, there will be a new norm. I think all of us agree, there will be a new norm, isn't it, in everything that we do. But for our personal lives, with the liberties returned to us, what can we do? What is essential and what is not essential? For all of us, that changes somewhat. For some of us, religious gatherings may be extremely important. For some of us, maybe not so much. And I'm using that as an example because how essential an activity is depends on each of us individually. And we have to balance that. I have a 90-year-old mom who lives in a nice nursing home, but I've not seen her for the last 6 weeks. You might say I'm a bad son. She says that as well, so you're probably right. But I dare not go and see her, many of us. She'll say, yeah, that's your stupid excuse. Probably right as well. That's my mom, what to do. I still love her.
Okay.
But the home has suggested that we don't go and see them because we might bring infection to the old folks there, and and it will spread like wildfire, just like in Washington State. So that's a new normal. How do I see my mom now? And that is through social media. luckily, so when I call her on the phone, they'll use the phone, they use the WhatsApp, things like that. So what I'm suggesting is all of us need to create our new normal. But what is clear is, number one, a heightened sense of hygiene, especially hand hygiene. Universal masking will still carry on, especially when you go into a public space. And of course, ask ourselves, how essential is this event or this place I'm going to? Can I make it safer? Now, some of it will be controlled by the proprietors. You go to the hypermarkets now or supermarkets, whatever. Many of them have some guidelines in place, like X number of people can go into the store at one time. But at the aisle, it's still free for all. And I'm sure you notice many men doing shopping for the very first time. You go to the aisle, and Prof. Thomas, you also say, I'm sure, go to the aisle, pick one tin food, take 3 years to pick one tin food because don't know what to pick. If you take the wrong food, go home, your wife will give you my wife will give me an earful. I can see all of you get the same problems. So we get stuck in the aisles. So we suggested there should be a floor manager from the hypermarket to try to move people around. So some of these things are what companies and supermarkets or organizations can put in place for their customers. But at the end of the day, it boils down to us. What is my new normal now? What is my new normal? And I just highlighted the 3 things: social distancing, universal masking in public spaces, and a heightened sense of hygiene, whether it's your hands or whether in common touch surfaces.
I thought you could have just created a new job scope for the supermarkets. So
yeah. I'm retired, so I got to find some job now. What to do?
I see.
Life is bad. Life is tough. Gosh.
So we've heard terms like isolation, quarantine, and social distancing, and can you help us to define exactly what these terms mean?
Okay. Oh, basically the concept is the same. It's the same thing. You're pulling the person away from the others so that the risk of transmission is reduced. Isolation is often meant for the person who's infected. So if I have COVID-19 now, I'm isolated. I'll be kept in Hospital Sungai Buloh or Hospital KL in the Klang Valley or UMMC, and I'll be kept there until my swabs are clear, then I can be released. So I'm being isolated. Quarantine are people who do not have the infection yet, who may have the infection or incubating perhaps, all right? The context, if you like. So the concept's the same. Because you might be infected and you may transmit, I'm going to put you aside to quarantine you. So that's the big difference between isolation and quarantine. The concept is very similar. You mentioned the other concept, of course, is social distancing, isn't it? Social distancing is therefore is for everyone. Isolation is for those infected. Quarantine are those who are exposed, who may be infected. And 3, social distancing is for all of us. And that's a usual 1 meter to 2 meter apart. The things that all of us know by now.
Thank you, Dato. That's very clear. So let me move on to Prof. Chong. I want to continue the thread about testing and why do we get false positives or false negatives? So maybe you can explain what that actually means for us and why do we have it?
So, as we are talking about testing, so accuracy of the test is very important. It's measured by 2 parameters: specificity of the test and sensitivity of the test. So, sensitivity refers to the level at which a certain protocol can detect the presence of the biomolecule that is designed to detect. So the higher the sensitivity, that means more sensitive is the test. So the less the biomolecule, like let's say you are detecting virus RNA in RT-PCR, so the less virus RNA is required for you to get a positive result. So tests which have a high sensitivity will have a lower chance of getting a false negative result. So what do you mean by false negative result? So false negative result means that actually the person is infected with the virus, but your test result shows negative, and the person interpreting the result will think that this person is not infected. So that's what is meant by false negative. On the other hand, false positive result means that you are not infected with the virus, but you get a positive test result. So for that one, we have to talk about specificity of a test. So specificity of a test refers to how well the test is able to distinguish between the virus agent that it is designed to test for against other closely related virus agents. For example, for the COVID-19, we are testing for the SARS-CoV-2 virus. But there are some viruses like the SARS coronavirus, which led to an epidemic or outbreak in around 2009. And then there's the MERS virus, the Middle East virus, which are closely related to this SARS-CoV-2. So tests with very high specificity will have a lower chance of declaring a false positive because it will be able to distinguish between the other closely related viruses. So on the other hand, there are some tests that, for example, there are some antibody tests which are not very specific. So if a person is infected with other closely related coronaviruses, then the person may get a false positive result, even though he or she is not infected with SARS-CoV-2 virus. In fact, there's another virus known as the coronavirus 229E. Okay, it is a coronavirus that causes common cold symptoms, but occasionally or rarely it may cause some acute respiratory symptoms. So it can come out or it can interfere with some of these antibody tests. So therefore, when interpreting some of these results, it is always, actually some of the clinicians recommend that we combine the antibody test with the RT-PCR nucleic acid test in order to get a better picture of the status of a person. So I hope that answers your questions, Tony.
Well, yes, it just makes me think that I don't want either a false positive or a false negative. They both have their challenges. Can I ask you about, and obviously it's a challenge to test everyone in the country. So who should be getting these tests? And how often should we be getting tested if it's a serological test, for example?
At the moment, actually the Ministry of Health has very clear guidelines on testing. But by and large, any individual with symptoms that are similar to the symptoms of COVID-19 should get it checked out. First, maybe either at a hospital, or if the person is staying far from the urban centers, maybe a person can go to the health clinics, okay, or the district clinics or district hospitals and get it checked. So there will be special area designated for testing. So the samples of these patients will be collected and then will be sent to the relevant hospitals which have these facilities to be tested. So, but also patients who do not have, or individuals who do not have symptoms, but in close contact with a COVID-19 positive patient, or have attended an event or been in a place that is known to be to have an outbreak of COVID-19. So it's highly encouraged that these persons should go and check out and get tested. So as for how often to be tested, so those who have the suspicion, patient under suspicion or under investigation, the ministry uses the term PUI, which means under investigation. So they will have to go for the test, and depending on the test result, this person may be placed under home surveillance or be admitted to the hospital. So if the patient is admitted to the hospital, of course the hospital medical officers will monitor the patient's situation, how severe is the symptoms. So if the patient is recovering, so usually by day 13, they will take another sample and do another test. If the patient has a negative test and no symptoms for I can't remember, it's whether no symptoms for the past 48 hours or 3 days, then this patient will then be discharged. So that is currently the guidelines from the MOH in terms of testing.
Okay. Okay.
But,
Thank you.
also,
Sorry.
I think we also read from the news, right, about the ministry wanting to do mass screening. So this will be very near possible future, as the ministry has already worked with the Beijing Genomics Institute to install 2 very high throughput machines in IMR and also in the Kota Kinabalu. So this will increase the testing capacity to more than 16,000 tests a day.
Yeah, even 16,000 is still not quite near as high as we would like to be. Yeah.
Yeah.
Okay, thank you, Prof. Chow. Prof. Thomas, what exactly is the solidarity trial, and how soon can we start to see outcomes from this?
Okay, before I answer your question, let me just go out from the topic a little bit to address Prof. Dato Chris's comments about grocery shopping. So Dato, in my home, I'm exempted from grocery shopping because I don't know the difference between the red onion and the green onion and or the garlic, the different types of garlic, the different types of dal. I'm only limited to buying bread, ice cream, dates, and bananas, nothing else.
Okay.
And to compound matters further, I'm colorblind. So if my wife asks me to buy red chili, I may end up buying green chili. So I'm totally exempted from grocery shopping.
Prof, I'm going to take your excuse. I'm going to follow your excuse. Just don't tell my wife, okay?
Okay, sure.
Good.
Sure. Okay, to answer, Tony, your question about the solidarity trial. It's a worldwide, multi-country, multi-site trial that is led by WHO. And Malaysia has been invited and has agreed to participate in this trial. And we currently have about 9 hospitals, Ministry of Health hospitals, who are participating in this trial. So this trial is looking at the efficacy and safety of a number of drugs that are already approved, and remdesivir, which has just, as an experimental drug, has just come in. Like I said, all these drugs that are in the trial are not specific for COVID-19. They have been in the market for different things. For example, one of the combinations that is being tested is lopinavir and ritonavir. This is an interesting combination of 2 antiviral drugs, and this is a good example of synergism where one drug increases the efficacy of the other by preventing its removal in the body, metabolism, preventing its metabolism. And so there is a higher, lopinavir inhibits the metabolism of ritonavir, and there is a higher and longer concentration of ritonavir in the blood. So that's another combination that's being trialed. The third one has got actually nothing to do with antiviral effect, that is interferon beta. Interferon beta is approved for the treatment of multiple sclerosis, but it is often used to calm the body's response to immune response. And it is, there is in an infection like COVID-19, there is what is known as cytokine storm, where large amounts of cytokines are released, and it causes a lot of inflammation. For example, the mucus and the fluid accumulation in the lungs. So interferon beta is being used to try to see whether its anti-inflammatory effects can help in the treatment of COVID-19. Then the other two that are being looked at is chloroquine and hydroxychloroquine. Now, how long this trial will go on, I think the first patient was recruited last week in our country, or 2 weeks ago. They continue to recruit. If the effects are very prominent, then the time taken to complete the trial may not be that long. But if the effects are very minor and cannot be distinguished, then it may require a longer time. But we also need to know that the number of subjects are not just limited to Malaysia. Many other countries are also doing it. So we have a larger population who is undergoing clinical trial. I'm not sure if, Dr. Chris, you want to add something to that?
Yeah, thanks, Prof. Exactly right. Sungai Buloh is one of the main hospitals, obviously, and we have started recruiting. I think we are close to about 15, 16 patients already. Remdesivir just has finally crept into the country, so we'll be recruiting for that as well. But the whole idea about solidarity trial is try to get data as fast as possible, because everybody is chipping into it. So we are probably quite expectant to be able to get some data within at least 6 weeks or so. I'm sure it'll be recruited very quickly. Yeah, so it's a good way of doing it faster.
How does one get on the trial, and what are the criteria of people accepted into these trials?
There is an inclusion and exclusion criteria, so that we are picking patients who are obviously symptomatic but not too ill. Obviously, because they are too ill, there are many factors that come into play. So wherever you're recruited, whether you're recruited in Malaysia or in another foreign country, you apply the same criteria. So it's like for like, rather than mixing a basket or full of different apples and oranges and pears, so difficult to interpret the data. So that's a good thing about having a multi-country, multi-centered study, because we can get data very, very fast. But in Malaysia, I think if you count the other hospitals, we are approaching about 20 patients already. All right. There's no limit to it, so we can recruit as many as we want to. But as you know, I'm sure you noticed, the good news is our number of new cases have dropped. So if you want to do this study for new patients in China, it's not going to happen. So you got to go to see Donald Trump's side, maybe.
Okay. So I have one question on therapy. I'll address it to both Prof. Thomas and Dr. Chris. Transfusion of plasma from recovered COVID-19 patients. How does that work, and is that a viable option?
So, Tony, the rationale behind this is that the person who has recovered from COVID-19 infection will have high levels of antibodies to COVID-19 in their plasma. And if there is some way in which we get the plasma of this patient and either concentrate it or isolate the antibodies and then inject it to a person who has the active infection, that it will be able to treat that infection. That's the rationale behind it. Whether it works in this situation, it has worked in some other situations where immune globulin is used for treatment. But whether it will work in this situation, we are not sure yet. There are people who have already volunteered, who have recovered and volunteered for the plasma to be taken, and they have donated their plasma. Around the world, this has happened, and some patients have been injected with the plasma, and some patients have been injected with a derivative or the antibodies isolated from the plasma. But the jury is still out whether it's effective or not. The US FDA has just approved in April approval for clinical trials of such products. And Microsoft is also planning to launch a tool for those who have recovered from COVID-19 infection. It's called COVID-19 Plasma Bot. Plan to launch that tool. And if you have recovered, you can use that tool to sort of determine whether you are eligible to donate your plasma. Not everybody will be eligible. You don't want to pass on some other condition that you have to the patient who receives your plasma. So there is some kind of a move like that. So it is still in its early stages. The rationale is good. It is an approach that has worked in some cases in other diseases. I'm not sure. We need to find out whether it can work in this.
Dr. Chris, is there anything you'd like to add?
Well, as Prof mentioned just now, there are some anecdotal papers that showed there's some benefit to it. But we had the privilege of talking to some of the Chinese doctors who came from China last week, was it? The week before. Two groups came. One group came from Shanghai. One group came from Shanghai. That one we did a virtual meeting with. But last week was the group from Guangdong. The Guangdong group said that they have tried it only occasionally. They have not used it in any big way. So they don't have much data from Guangdong. The Shanghai people have not used it in any big way. So I think the papers anecdotal studies are still pretty small. In theory, I agree with Prof. In theory, it sounds attractive. It should work, isn't it? But I think that, as he mentioned just now, the jury is still out on this. But in Malaysia, it's not going to be something easy to do, because if we are dependent on our infected cases, we may not have that many to talk about, because to harvest it is not the easiest thing in the world to do as well.
Okay, thank you. So I'm going to take a 1 minute for a housekeeping announcement. As I've said earlier, we've asked our audience to hold their questions until around now. So you may start typing in your questions to the panel. I see some of you have already done so. And I think we may have covered some of the questions here already. And as we continue with our discussions, I will try to convey as many of those questions as possible. Okay, so the next thing I wanted to talk about, perhaps with both Prof. Chong and Dr. Chris, it's about immunity. So you talked about building up antibodies once you recover. Can you be reinfected? And will the disease be as severe the second time around?
Prof. Chong, you go first?
Okay. Dato, maybe you can go first.
No lah, you go first lah. See, I'm so polite. Okay. No. Okay. Never mind. You bully me this time. Next time I bully you back. Okay? Yeah, fair and square there. The short answer is no. We don't know that for a fact. In theory, like most other viral infections, there should be some amount of immunity. The question is whether the immunity is partial or full. Is it short-lived, or is it for the rest of your life? In theory, it should have some protective benefit to the infected patient. But at the moment, as WHO repeatedly said, we do not know yet. So we will have to wait for some of these studies to come through. This is huge, because obviously the vaccine development will be very much linked to this. But the data is not really there yet. The other issue, of course, is if you're talking about immunity, the earlier question that Prof. Chong answered about doing antibody tests, The other problem with antibody tests is there's still a fair number of tests that's not very reliable yet. And WHO just came up again yesterday or the day before saying that they have not found one that is very robust and reliable yet. I'm sure that's going to come, and I'm sure Prof. Chong can talk about it more about it. But at the moment, what's in the open market, it varies greatly. So we have to be careful which one we buy, because as you rightly said, false negative is not good. False positive is also not good, and that could be very dangerous. So now, Prof. Chong, you are.
Prof. Chong?
Okay, thank you. Sorry, I was muted. Yeah, just like what Dato' Chris was mentioning. So we have currently no knowledge whether the antibodies produced by a person who is in the recovery stage or already recovered, how long those antibodies will be there and whether it will be a protective antibody or not. So we still do not know, and a lot of studies are underway. And also, like, for example, is it possible for the pregnant mothers who are infected to pass on the virus to the neonates in the uterus, or would the mother actually have any protective antibodies, that the baby will also benefit from that. So, like as for example, in the breast milk, for example. So we still do not know. There's still a lot of question marks right now. And also for the vaccine, like what Dr. Chris was mentioning. So even we can see, like for seasonal flu, influenza, every season the virus will mutate, and then you have to come up with new vaccines that will be effective for the new season of influenza viruses. So we still do not know whether for SARS it will be the same as well. I mean, certainly from the literature we can see that some researchers have published, they have sequenced the entire genome of some of the viruses that they cultured from patients, and they were able to detect some presence of some mutations, whether it's a single nucleotide change or a few nucleotide changes. So as this is happening, we need to gather more data and check whether, even if a vaccine is being developed, how effective will that be in the future?
Thank you, Prof. Chong. In fact, actually, this is a question from Nor Hayati. So, knowing that there are potentially different strains, how complicated will it be to produce a vaccine for all?
Who should? Okay. Who is going to answer? Yeah, like what I mentioned also. Yeah, for the vaccine development, so it's quite challenging. Certainly, more genomic data needs to be compiled across the world in order for cover more strains and yeah.
So this is
Perhaps I can add here a little bit.
Yes,
sorry,
Dato'.
I couldn't hear you very well, Prof. Chong.
Sorry.
Yes, Dato', go ahead.
Okay, just that I think all of us are familiar. They talk about the strains A, B, and C and things like that. And I think this question was also discussed with Anthony Fauci. I read one of his interviews. I'm certainly not a virologist and not a vaccinologist, but most of the vaccine companies are focusing on the very preserved or conserved part of the genome, so that whichever strain you are, it's likely to cut across all the different strains. They are aware of these different strains, so obviously they want to find a common target for the vaccine development. That's what they said. That gives us a bit of reassurance that they are aware of this and they are looking to deal with that.
Okay, thank you. So there's a question here about the comorbidity and fatalities from COVID-19. Could you add light on that? Dr. Chris, perhaps I'll start with you.
Right, okay. I can tell you a bit more data because today we just presented at Ministry our mortality findings. Certainly, looking at the 100 cases, 100 deaths that we have had in this country so far, 75%, was it 80, 78%, sorry, have patients who have passed away have comorbidities. In fact, out of this 78, a large proportion, more than 3/4, got more than one comorbidity. And the most common one is hypertension and diabetes. We have a fair number of people with CKDs or end-stage renal disease even, and a few with ischemic heart disease and heart failure. We have not seen anybody who is immunocompromised in the sense of having HIV and the other things. But we only have 100 deaths, so we can't say that for everything. But comorbidities clearly mark out who is more vulnerable to this infection. And the other clear thing about comorbidity that we also notice, of course, it's morbid obesity, and we have had a few patients who are morbidly obese who have passed away. Now, I can only share with you the data that we have from the mortality review. I don't have access to the individual breakdown of all the cases that were admitted to Sungei-Buloh, HKL, UMMC, because that's also equally important. If we just look at the deaths, you only see one side of the coin. You've also got to look at those who have done well, who have survived. And that's not the remit of my committee, so I haven't got access to that yet. But the biggest one by far, besides comorbidity, the biggest liability or weakness for patients who are prone to get complications is the age. If you look at those who have passed away in terms of age-specific mortality rates, if you are above 80 years of age, your risk of mortality goes up to 20%. Whereas if you are in between 30 to 40, your risk of death is only about one point something percent. So that curve is exponential in that sense. As you get older, closer to 80, even in Malaysia, we see that mortality rate shoot up significantly. Yeah.
Okay, now that you mentioned that about the age thing, I think there was a question here also about are we doing enough for our home care, aged home cares, and perhaps I'll invite Prof. Thomas to weigh in on this.
Thank you, Tony. I'm not sure if I'm qualified to answer that, but I think the Malaysian home care setting is very different from what we see in the news in UK and all that we have very established home care where the homes are run by professionals. They can isolate the patients, but even in those cases, the mortality rate, especially in Britain, has been very high. So home care generally means they are elderly, like what Dato' Chris said. They are also the age that is most vulnerable. And so extra precautions should be taken in limiting visitors who come to see them. They may not be able to see their grandchildren. So I'm speaking in terms of aged care. I'm not sure if that's what you meant, or care at home, but aged care. Those places, one person gets it, then it can spread very quickly. The carers who take care of them need to take all the precautions of hand hygiene and mask and all the protection so that they don't pass it not just to themselves, but from one of the elderly to another. So unfortunately, our aged care facilities, although there is a law now to somewhat regulate it, but it's not as advanced as in some other countries. Ours is mainly someone renovates a bungalow and makes extra rooms, and the elderly are sent there. But that's better than neglect. It's better than neglect. But a lot of chances for an infection to spread in the current setting.
Thank you. Dato' Lee, are we doing enough in terms of testing of aged care in our country?
I mean, at the moment, at this point in time, the answer is clearly no. As Prof mentioned just now, I think in Malaysia, our setup is not structured. Those who are licensed, at least they are under the monitoring of the Women's and Family Development Ministry. It's not under MOH. Right? But I think all of us know there's also many homes that are not licensed, as Prof mentioned just now, and they're scattered all over the place. Now, the good news is the Malaysian Society of Geriatric Medicine has worked with Ministry of Health to come up with guidelines. I'm aware of that. I've seen the guidelines. So that has been done. That was probably about 2 weeks ago or something like that. Now, I'm sure that has been sent out, but whether these homes have the ability or the political will or the financial will to implement some of this, I can't tell, all right? How well they are monitored, I don't know. But for example, in the home that my mother is in, I can thank you frankly, about 2 months plus ago, before the MCO, the proprietor person in charge was talking to me on how to make it safer. And I was given advice. So up to 2 months plus ago, it wasn't there, right? And of course, testing now, as Prof. Chong mentioned, it is still limited in many ways. It will get scaled up in the next week or 2 weeks. But the question is this, there are a lot of people in Malaysia you need to screen. The question is now we have to ask our question, who do we screen first? I mean, I'm being frank, I'm not arguing with MOH or, yeah, we will never screen everybody. We don't need to screen everybody. The question is, who do we screen first? When this 250,000 antigen test comes in, who do we screen first? If you just screen whoever comes to the front door, you will finish very fast, but you still may not get a targeted screening. Now, clearly, I'm sure he's focusing on the foreign workers to some degree, based on what's happening now in the wholesale markets, etc., etc. Maybe even the refugees or perhaps. But what's the other group? We all know that we should protect the elderly. We all repeatedly say that. And I would totally agree. I hope there's a focus towards that. But how do we get all the old folks together? Those who are still living with families, then of course it's for the carers, for the sons and daughters to organize it. But those in the homes, if they are within the purview of the Ministry of Women and Family Development, perhaps they can target it and get them screened. But screening and testing is only one thing. If they are tested, they must have the ability to isolate them. Of course, if they're positive now, they'll end up in the hospital because our policy is still to admit everybody who's positive at the moment. But the question now is, besides screening, once you know that everybody is negative, what do you do to maintain them being negative? And that needs the understanding and the education of people who run these homes, and the guidelines need to be quite detailed. Hopefully they have the ability to do it. It might mean charging the families or carers more money. It might mean that. And nobody will be happy with that, obviously, isn't it, upfront, especially with economies like this. But they may have to do something to protect the elderly. And here, maybe the Ministry of Women's and Family Development can do a bit more to support them. The cost of testing will come down. With the antigen testing coming in, the cost will be significantly cheaper than the PCR test. Clearly. So let's watch this space. I hope there will be some good developments in that area.
Okay. Now there's quite a specific question here about the incidence of COVID. Is it underrepresented in HIV patients or HIV patients receiving heart? Maybe I'll invite you, and then after that, Prof. Chong, to take this one.
So everybody on lopinavir, yay, you're protected. You've got a double thing there. Perhaps you could be right. I don't know. You know, there have been talk about using hydroxychloroquine as prophylaxis, isn't it? I'm sure when Donald Trump came to tout it, people talked about it. Well, there could be some benefit there, but certainly we have not seen sharp uptake of HIV positive patients with COVID-19. Not in the data. Certainly among the 100 deaths, we have not seen one mortality in an HIV positive patient. I can't tell you those other 5,000 over who have survived. I don't know. I don't see all their data. Right? But hearing from my colleagues in Sungai Buloh, they did not talk about that at all. That didn't seem to be one of their major concerns. So perhaps you're right. But having said that, only a minority of patients are on Calitra or lopinavir because it's our second-line drug, isn't it? And Prof knows how expensive it is. So we don't use it routinely. It's certainly not the front line or the first-line regimen. So well, maybe the community spread is not as big yet. Let's hope it stays that way.
Chong?
Yeah, certainly. Like what the topic was mentioned, because sorry, is my line breaking?
Yeah, yeah,
Yes,
we're
yes.
losing your audio.
Maybe I stop my video and see whether that helps. As Datuk Chris mentioned, yeah, because the HIV patients antiviral drugs, so it could be that it's offering them some level of protection.
Prof. Chong, we are losing your audio.
Oh, I see. Hello, can you hear me?
Okay, now it's better, yes.
Right. Yeah, so it could be that the antiviral cocktails that HIV patients are receiving are sort of protecting them from COVID. So, in fact, Dr. Wong and myself, we are writing a review paper on this topic currently,
Okay.
HIV and also.
Okay. We look forward to your review paper. Please circulate it to this group here.
Yeah, if it gets published and
Okay.
accepted.
Okay, so let me move on to some rather interesting questions. I have a question here about practical advice for pet owners. As we know, there is now reports of infectivity in pets. So who would like to take this question? Prof. Thomas, you have a dog.
Yeah, we could hear him barking away.
So perhaps I'll ask you to comment on this.
Yeah, I mean, yes, there have been reports that pets can also be COVID-19 positive, but whether they can transmit to humans, I mean, those things we don't know yet. What exactly does it mean when a cat or a dog is COVID positive? So I think we still don't have enough information. I suppose the things that Dr. Chris mentioned about hand hygiene and all that can still be practiced with a dog, although no point having a dog or a cat and you practice social distancing. It defeats the purpose of having it. But yeah, I think pets thing is still not. It seems amusing to hear that pets can also get the viral infection, but what is the significance of it? We don't have data yet.
Okay, thank you.
Well, we don't know whether the pets may infect us or whether we infect our pets. As you know, my stupid, I didn't say the word stupid cat. My wife will get upset. My dumb cat will lick and everything under the sun. I mean, if it's COVID positive, he may get it from us. So my only advice is for those of you who don't like your pets, social distance, keep them far away.
Oh dear. Okay, so here's another interesting question. Can you get infected from buying stuff from the supermarket like fruits and vegetables?
Not Prof. Thomas, okay?
I hope I'm reading this question correctly.
Well, I can try and answer, but actually I heard it from Dr. Chris when he talked at another forum.
Okay.
Asked, and he said, what should his advice to people who buy stuff from the grocery store and come back home, what should you do? So one of the things he said, you can wipe those things down. If fruits and vegetables, you can wash them and then only store them in the fridge and things like that. But otherwise, again, there is evidence that the virus stays alive on surfaces. It depends on the temperature of the surface, depends on moisture and things like that. But those are very difficult to completely control. You can only take precautions. Again, hygiene, personal hygiene, and also make sure the stuff that we bring into our homes are clean. Those kinds of things. But wiping down packages that we bring from the supermarket, we practice that at our home. Washing the veggie, things like that. But are we going overboard? I don't know. It's just taking precautions.
We
What
probably
about-
are going overboard, but well, I think it's probably the new norm. We know, as Prof mentioned, the data is it can survive on a cardboard box for up to a few days, isn't it? So that risk is there. So if you can wipe it down, by all means do it. But I'm not saying there's been no proof that that can cause an infection. That is a fact. Yeah. And I'm very surprised. I think, Prof, you're the only person listening to me, I think, that day.
Well, at the very least, you're washing away more pesticides. Okay, what about temperature? There's this debate about high temperature, humidity. Does that work for nCoV too?
Please don't tell Donald Trump. He might ask you to go to the sauna. Well, the clear thing is this. I think the higher the temperature, the virus doesn't live as long outside our body. We know that for a fact. And the more humid is it, they may not survive so long. But as Prof mentioned, it is not something we can control, all right? I'm certainly not going to move to Sahara Desert to avoid this, that kind of thing. So if it's there, it's there. It helps. But again, was that the reason why SARS disappeared during the summer of that year? People think it contributed to it, but I don't know. So it's interesting, yeah, but I don't think it changes it can help us change our behavior. We can't turn on the humidity, we can't change the temperature, Can you imagine if we say, switch off all your air cons? Can you imagine that? You'll be the emoji. Remember that one? So that's not going to happen, not in my household. Yeah. So,
okay, Prof. Chong was
I think so. It's back to our own practices, probably more important. Yeah.
Okay, thank you. Prof. Chong, you're about to say something?
Oh yeah, I was just going to mention that there were some studies done on SARS virus where they showed that if they heat the virus to 70 degrees, 65 to 70 degrees, it can inactivate the virus. But of course, that is not possible for us like humans to that temperature. Yeah. The most important thing is still like what Datuk says, hand hygiene, and don't touch your face or your nose and your eyes, because that's the main route of transmission.
Okay. So I have a pretty interesting question here. What role do genetics play in our susceptibility to COVID-19, if at all? So perhaps this is in Prof. Chong's area and Dato' Chris, perhaps. Prof. Chong, can you lead off with this?
Right. Okay. At the moment, so there is still no concrete study about the role of genetics, but we do know, of course, like the virus actually and how the virus enters our cells through the ACE2 receptor. So maybe if there's a polymorphism in this gene, the ACE2 receptor, maybe some of these polymorphism have lower chance for the virus to bind or something. So it could affect the risk of a person getting infected. And the other thing, of course, is our immune system, because the complications of this COVID-19 is due to the cytokines being overreactive. What Prof. Thomas mentioned just now, cytokine storm. So everyone's genetic makeup is different. How our immune system responds to virus infection is also different from individual to individual. So I'm sure that to a certain extent, our genetics do play a role. Yeah.
Dato' Chris, do you want to weigh in?
I have nothing clever to say.
Okay.
So my mother taught me, if nothing clever, they say keep your mouth shut. But knowing me, I can't keep my mouth shut. Early on in the outbreak, I was interviewed by Star, on their video or YouTube channel or whatever. And the first question they asked me, for crying out loud, was, does the virus like Chinese blood? How come only Chinamen getting it? I said, because it's in Wuhan lah. Duh. I mean, what? Well, I'm glad I was proven right. It has gone around the world now, so everybody is getting it, not just what to do, people. Well, I have nothing clever to say about that. I think everybody is probably generally quite vulnerable to catch it. What Prof. Chong mentioned just now, certainly there's possible truth in that, but we just don't know at the moment. So basically, all of us are.
The data is not enough yet, but maybe the severity of our symptoms, different people may be asymptomatic, but others, have more severe symptoms. So probably the genetics do play a role in this, I feel.
Well, there's one group that certainly stands out, children. Thank God for that.
Yes,
The kids so far has been pretty good.
Right.
They do get infected, but certainly very few of them have severe symptoms. I know that pediatricians in Sungai Buloh are much more comfortable than the ID physicians, that's for sure. And that's good news. So some people say, oh, therefore it's probably okay to open the schools. But of course, the other concern is if the kids catch it, they give it to their grandparents, or that concern is there. But the good news is, but that one probably not genetics, but it's just how they deal with this virus infection. Yeah, maybe the cytokine storm thing is not so big in kids, perhaps.
So this leads right into the next question that I have from obviously a concerned mother. When schools finally do reopen, what should we do? Are there preventive steps, things to take note of? Maybe I invite Prof. Thomas to mention something about this.
Well, yeah. So I'm sure many parents are concerned about this when school reopens. So on the positive side is what Dr. Chris mentioned, that children don't seem to be infected so much, and if they do also, it is not very severe. But our children also should still practice hand hygiene, social distancing. Is that going to be possible in schools? Those kinds of things have to be considered. And probably even more important is when they come back from school, how well do they clean themselves, especially if you have parents and grandparents who are elderly living at home. What are the precautions that they should take when they come back home? I think that is probably more important. But if a more fundamental question, I think, is which I'm sure parents will think, should I send my child to school or should I homeschool them? That's a different discussion altogether. Then you end up trying to live as a hermit, and not meet anybody. But that's a decision that every family has to make. When schools reopen, hopefully by the time schools reopen, we have a vaccine, then the risks are less. A good, effective vaccine. If we don't have a vaccine, hopefully we have a good treatment, and the risks are even lesser. Okay, but I'm sure many parents are concerned about that.
Yes. Okay, thank you. I'm afraid we've run out of time, so I won't be able to field any more questions from the audience. But like I mentioned earlier, the panel is okay for you to write directly to them with your questions, and they will try their best to answer you. Now, before we sign off, maybe perhaps a last question for all members of the panel here. What would be our biggest takeaway, our learning lesson from fighting COVID-19 as we perhaps get prepared for the next epidemic or pandemic? Could I lead off with Dr. Chris?
Okay. Well, I mentioned that a little bit earlier on in our webinar. I think the biggest thing that all of us can do for each other, for ourselves, and for the country, I'm sorry, I know I sound like a politician now, is really to plan how we'll run our lives post MCO. When the government is no longer instilling us a set of rules, what do we do? Now, this is important. At the end of the day, we have 33 million people living here, whether they're citizens or non-citizens. We are interconnected. So if a sizable portion of us do not adhere or follow the principle of social distancing, improve hygiene, there's going to be another cluster. That's for sure. You know that. And this has been shown in other parts of the world as well. So to me, we cannot depend just on the government or the Ministry of Health because they cannot control everything that we do. At the end, it's our own decision on how we plan to decide what is our new normal. And that we need to do. And that's going to happen pretty soon. I'm sure we know the MCO cannot run forever. The economy just will not allow that to happen. You know that, I know that. And the government, you can see they are also already finding steps to open things gradually. The numbers that are low now also allows us to do that. We just hope that the Ministry of Health has done enough surveillance testing to know what is the true situation out there. So I think all of us need to start planning our lives. As Prof mentioned the example of the kids, if the schools open, how comfortable, how can we be more comfortable for our kids to go to school? Going to school is part of the norm. I don't think that will change. But what can we help get our kids to do to make it safer for them? Yeah.
Okay, thank you. Prof. Chong, in terms of science, research, and technology, what takeaways can we learn from this pandemic for the future?
One thing that really, I think, impressed me was how the scientific community worldwide, globally, work together very rapidly. For example, when the outbreak occurred, China moved in very fast, sequenced the whole virus genome very quickly and shared it to the whole world, the whole scientific community. And it is this kind of spirit of sharing that we should really take hold of, so that more investigators and researchers can actually engage in trying to find new therapeutics and new diagnostic tests and so on in order to combat this pandemic. So it's actually basically working together as a team everywhere, not just within country, but between different countries as well. So for me, I think that's the main take-home message.
Okay, thank you, Prof. Chong. Prof. Thomas, besides learning that you're colorblind, what takeaway should we remember from this fight against COVID-19? Prof, your microphone.
Sorry, I muted myself. Yeah. Apart from, what Prof. Chong and Dr. Chris have mentioned, I just want to say that, many analysts and commentators now say that life won't be the same, the world won't be the same, things will be different. And that is true to some extent. And so I just like to, because we are in that business of education, that there will be an impact on education and how it is delivered also. Whether we will be able to come back to our campuses and do things as before, whether it will be, all distance learning. For the present season, tailors have managed to, because of advanced planning, has managed to go almost seamlessly into online. But can this go on for another one semester? Can it go on for 2? So the way we do education is probably going to change. With the condition, if we don't find a cure or if we don't find a vaccine, the way we do education is going to change. And I'm sure people like Microsoft and all these other people are looking at solutions that they can supply to universities and educational institutions using virtual reality, simulation, artificial intelligence, so that coming to the campus in large numbers may not be necessary. So I think that is one of the changes that we have to be ready from an education point of view. I'm not taking away anything that Dr. Chris and Prof. Chong said, but specifically for the education sector, we have to look at delivering education in a different way.
Thank you very much, Prof. Thomas. So we have to end our session. I would like to thank all three panel members very much for spending the afternoon and sharing your thoughts with us. Thank you.
Thank you,
And
Tony.
for all of the participants who have dialed in from wherever you are, thank you for staying with us right to the very end. I hope you found this useful. Be well, stay safe, and I hope to see you in person after the MCO is lifted. Thank you. Bye-bye.
Thank you. Thank you, Tony.
Thank you. Thank you, Prof.
Thank you.
Thank you, Puluan and team at the background.
Yeah, thank you, Puluan and team.
Thank you.
Prof. Thank you, Prof. Yeah.
Did you have to kick anybody out? Okay, have you,
All right, guys. Thanks. Bye.
did we have any Zoom bombers? Puluan? Okay. Okay, great. So let's do a quick post-mortem after this. Once people have left the chats. Hello. Okay. I think we are.
Are we the only ones in the room?
Yeah, I think we're 6 of us left. So Puluan, could you actually remove people from the room one, or they have to leave? Okay. Oh. Oh, I see.
Or
Okay.
you can do that. Okay.
Okay.
Without them knowing or with them knowing?